Hello, my name is Claire Harrison. I'm a consultant haematologist at Guy's and St Thomas's Hospitals in London, UK. Today, I want to speak to you about panobinostat and ruxolitinib in myelofibrosis. Is combination the future of treatment? Panobinostat, a histone deacetylase inhibitor, was reported to have marked activity and benefit in patients with myelofibrosis in a study performed by Ron Hoffman and John Mascarenhas and reported in the British Journal of Haematology. Here you can see that a number of patients had significant benefit in terms of normalization of the bone marrow morphology after prolonged treatment with this drug. Interestingly, these changes were not seen after 6 months of therapy, but took up to 16 cycles to occur. At the same time, in an analysis of the benefit of the combination in a mouse model, it was shown that the combination of ruxolitinib and panobinostat led to the greatest efficacy in terms of disease bulk as measured using this immunofluorescent agent. Importantly, there was no major change in tolerability in these mice studies as assessed by body weight. As a consequence, a phase 1b dose-finding study of the combination of ruxolitinib and panobinostat was begun in patients with myelofibrosis. On this slide, you can see that this study had an initial dose escalation phase, and you can see the different dosing cohorts in the lower part of the slide, and then, of course, a safety expansion phase. Let's take a look now at the data from the safety expansion phase. In the safety expansion phase, where patients received ruxolitinib 15 milligrams twice a day and panobinostat 25 milligrams 3 times a week, a greater proportion of patients achieved a 35% reduction in spleen volume than those in the COMFORT-2 study. Here, 65% of these patients achieved this target reduction in spleen volume, when compared to 30% of patients in COMFORT-2 and approximately 40% of patients in COMFORT-1. Here is an analysis of these patients again when compared at 2 time points, at week 24 and at week 48. And you will also notice that patients are shown according to their myelofibrosis diagnosis, with patients with primary myelofibrosis on the paler bars and patients with post-PV or post-ET myelofibrosis in the darker orange bars. Again, you can see that durability of response was seen, and some patients had very dramatic reduction in spleen volume responses, with responses of up to 80% reduction at 48 weeks. So the conclusion was that this combination appears to deliver, at least in this small number of patients, better spleen volume responses than single-agent ruxolitinib alone. What about the data with regard to bone marrow fibrosis? 3 patients in the dose expansion phase had improved fibrosis, with fibrosis grades improving from 3 to 2, 2 to 1, and 1 to 0. Here you can see the figures for a patient whose fibrosis grade improved from 2 to 1. You can also see important changes in megakaryocyte morphology, numbers, and clustering. There was, of course, a mixed pattern of response, with many patients having either stable fibrosis and a couple of patients having a worsening of their fibrosis grade. On this slide, you can see the overall pattern of bone marrow responses in the dose expansion phase. Here, they're split by fibrosis grade response, correlating that with spleen volume response, and some data, which we'll look at in more detail, with regard to allele burden change. This is a very effective way at looking at the overall pattern of response and showing that there is no clear correlation between these different parameters of disease response in individual patients. Here is the data with regard to JAK2 V617F allele burden reduction in the 22 patients in this study who are JAK2 V617F positive at baseline. Here, almost 30% of patients had a greater than or equal to 20% reduction in JAK allele burden from baseline. And you can see below the individual patient responses. Let's take a deeper dive into the molecular status of patients on this dose expansion phase and asks a question about whether molecular status correlates with response. Here you can see data from a poster presentation at the ASH meeting in 2015, with the patients grouped according to their spleen volume reduction response, to whether they achieved the target response of a 35% reduction or not. And you can see that the patients are fairly heterogeneous with regard to the different mutations that they express, but there is no clear correlation between those patients achieving the target spleen volume response or not and the molecular mutations that are expressed by these patients. In summary, from the data we currently have available, we can conclude that the combination of ruxolitinib and panobinostat is well tolerated. Although we haven't looked at it specifically in detail in this presentation, I can share with you that anemia, thrombocytopenia, and diarrhea were the most common adverse events, but these were well controlled and consistent with those observed with ruxolitinib or panobinostat when given as a monotherapy. As we've seen, spleen response rates were better than those seen in the COMFORT studies, with overall 65% and 50% of patients achieving a spleen volume response at the two different time points. Reduction in bone marrow fibrosis and JAK allele burden was seen in some patients, but as we also reviewed, did not necessarily correlate with spleen response. We should conclude, therefore, that the combination of ruxolitinib and panobinostat offers important clinical benefit for our patients and is a potentially important treatment combination for the future. Thank you for listening today.